Welcome back to the Deep Dive. It is Sunday, February 8th, 2026. And if you're listening to this right now, there's a very good chance you are either currently stressed out or you're about to be.
Because it is Super Bowl Sunday.
The biggest day in sports.
Yeah.
The snacks are out, the jerseys are on, and millions of people are getting ready to just scream at their TVs for, 4 hours straight?
At least. And, we always talk about the physical toll on the players, the hits, the concussions.
Right.
But we almost never talk about the toll on the person on the couch with a handful of wings.
But it's a real thing, isn't it? I mean, the data shows that cardiac events, heart attacks, they actually spike during these big games.
Oh, it's a real phenomenon.
Yeah.
That emotional stress, it translates directly into electrical instability in the heart. You're just dumping adrenaline into your system, heart rate spikes,
Right.
blood pressure goes up, all while you're just sitting there.
Which is why, before we get into all the scary stuff, we should probably mention that this deep dive is brought to you by Whole Life Healthcare. They actually sent over a few tips for, surviving the game today without blowing a gasket.
Oh, really?
Yeah.
What's the prescription for a tie game in the fourth quarter?
Well, aside from turn off the TV, which, let's be honest, no one's going to do,
Never.
they suggest active stress management. So don't just sit there stewing. Stand up, pace a little, burn off that adrenaline, and deep breathing. Like actually regulating your breath during the commercials can help lower your heart rate. A little prevention is better than the alternative.
Because the alternative usually means a trip to the ER and getting hooked up to a machine.
Exactly. And that brings us to the real meat of today's deep dive. We are talking about that ubiquitous sound of survival. You know the one, beep, beep, beep.
The electrocardiogram? The ECG.
Or
EKG.
yeah, and we have this cultural assumption that the ECG is this ultimate truth teller. It's the impartial judge, right? If the line is flat, you're gone. If it says normal sinus rhythm, you're totally safe.
But the stack of sources we have today, it paints a much messier picture.
It really does. We're looking at sources that describe deadly masquerades, algorithmic hallucinations, and this phenomenon they call misfits.
The research suggests that a significant percentage of ECG interpretations,
Both from doctors and from the computer itself.
both are just, well, they're dead wrong.
So, just to set the stakes here, we're saying that the very tool used to decide if you are having a heart attack might actually be lying to you.
Or we might be lying to ourselves about what that tool is even seeing.
Okay, let's back up. To understand how the lie happens, we probably need to understand how it's supposed to work. I know the heart's a pump, but it's also, an electrical grid?
Exactly. Think of your heartbeat not as just a squeeze, but as a coordinated stadium wave. It starts at the top, in the SA node.
The pacemaker.
The natural pacemaker, yeah. It's the guy with the megaphone in Section 101. He shouts, and the signal just spreads across the top chambers, the atria.
And then it hits a checkpoint, right?
Right, the AV node.
Yeah.
And this part is crucial. The signal has to pause there for a split second. That pause allows the ventricles, the big pumping chambers at the bottom, to fill up with blood. If you didn't have that pause, you'd be pumping empty chambers. It'd be useless.
Okay, so the stadium wave pauses, everyone holds their breath.
And then boom. The signal shoots down what's called the bundle of His and out through the Purkinje fibers. These are like high-speed fiber optic cables.
Wow.
They trigger the main event, the ventricles squeeze, and blood shoots out to your body.
And the ECG is just a voltmeter measuring that whole stadium wave from the outside?
Correct. It's just sticking electrodes on your skin to catch those tiny millivolts of electricity.
Yeah.
But here is where the high-tech medicine runs right into a really low-tech problem.
I was reading Source 2, and I actually laughed out loud at what the #1 enemy of this life-saving machine is.
It's not what you'd think.
It's not some rare magnetic interference or something.
No. It's chest hair.
It sounds like a joke, but it's not.
It sounds funny, but it is seriously dangerous.
Yeah.
You have dead skin cells, sweat, oil, and then hair lifting the electrode right off the skin.
Which creates bad contact.
Terrible contact. And that creates artifacts. The machine sees the signal jumping around because the sticker is loose, but it interprets that as the heart jumping around.
So the machine is screaming arrhythmia, when really it's just hairy chest.
Precisely. It can mimic really dangerous rhythms, like atrial fibrillation. One of the sources noted that just proper prep, an alcohol wipe, a little gauze abrasion to scrape off the dead skin, it reduces these errors by 40%.
40%. But let's be real. In a crowded ER or maybe a chaotic ambulance during the Super Bowl, is anyone really taking the time to sandpaper a guy's chest?
Often, no. And that leads to false alarms. But there's an even scarier category of error, the misfit.
I love this acronym, even though the story behind it is, well, it's terrifying. This is from source 16. MISFIT, myocardial infarction simulated from improper telemetry.
Which is just a very, very fancy way of saying, we put the wires on wrong and now it looks like you're dying.
There was this case study of a 58-year-old runner, healthy guy. He goes in for a minor surgery, develops a little rhythm issue afterwards, AFib, which they treat. He's fine. But then all of a sudden, the monitor lights up.
Posterolateral myocardial infarction.
A massive heart attack.
Yeah.
So you can imagine the scene. Nurses rushing in, the crash cart is rolling, families panicking. But the patient himself, how was he?
He was fine, just sitting there, stable, probably wondering what all the fuss was about.
And this is where the art of medicine comes in. An astute cardiologist looked at the squiggly lines and just realized they didn't make any physical sense.
What gave it away?
The pattern was basically impossible for a human heart unless the wires were swapped.
The left arm to right arm limb lead reversal.
So, wait, walk me through that. Somebody accidentally put the left wire on the right arm and the right on the left?
Yes.
Just a simple swap.
How does that create a fake heart attack? I would think it would just look like a mirror image or something. Well, it changes the electrical axis. Remember, the ECG is calculating the direction the electricity is traveling. Normally, the big surge goes down and to the left.
Okay.
If you swap those arm wires, the machine thinks the electricity is moving in a completely different, bizarre direction. And to the algorithm, that specific shift looks exactly like the electrical void created by dead heart tissue.
So a simple typo with the wires creates a phantom heart attack.
And if that cardiologist hadn't noticed, that runner might have been rushed to the cath lab, given heavy blood thinners,
Yeah.
all because of a wire swap.
That is wild. Okay, but that's a technical error. A human messed up the setup. What about when the wires are right, the machine's working, but the interpretation is a matter of life and death? This is where we get into the deadly masquerade.
This is the highest stakes dilemma. We're talking about distinguishing between VT, ventricular tachycardia, and SVT, supraventricular tachycardia.
Okay, we need to break this down. VT versus SVT. Why does the difference matter so much?
It is literally the difference between a nuisance and a funeral. VT comes from the ventricles, the bottom of the heart. It's chaotic, it's dangerously fast, and it can degenerate into cardiac arrest in minutes. The pump just stops working effectively.
And SVT.
SVT comes from the top chambers. It makes your heart race, you feel awful, maybe get dizzy, but it's generally not going to kill you instantly.
But the problem is, on the graph, they can look identical.
They can. They both show these wide complexes. Usually SVT is narrow, but if the conduction system is a bit wonky, what we call aberrancy, it looks wide. So you're faced with a wide, fast rhythm. Is it the killer VT or is it the imposter SVT?
And here's where doctors fall into a huge trap. Source 8 calls it the stable myth.
Right. The doctor looks at the patient's awake, they're talking, maybe complaining at the game score.
Yeah.
And the doctor thinks, well, if he had VT, he'd be unconscious. Since he's stable, it must be SVT.
Is that true? Can it not be VT?
Absolutely not. That is a dangerous, dangerous assumption. Patients can be wide awake and hemodynamically stable while in ventricular tachycardia.
Okay, so the doctor assumes it's SVT. They reach for a drug, verapamil. It's a calcium channel blocker. What happens next?
This is the nightmare scenario. Verapamil works by relaxing blood vessels and slowing the heart. If the patient really has SVT, that's great. It works. But if they have VT...
Why is that so bad for VT?
In VT, the heart is beating so fast and so inefficiently, it's barely pumping any blood. The only thing keeping that patient conscious is their blood pressure. Their body is clamping down on all the vessels just to keep blood flowing to the brain.
I see.
Verapamil essentially kicks the legs out from under that chair. It dilates the vessels, and the blood pressure just drops instantly.
So you remove the only prop holding them up.
Exactly. The floor falls out. You cause cardiovascular collapse. The patient crashes and can die. The sources call it a clean kill.
That's terrifying. You're trying to help, but because you trusted the stability myth, you make a fatal error. So how are you supposed to tell the difference?
You have to play detective with the graph itself. Source 19 talks about the forgotten lead EVR.
Lead AVR. Okay, so this is one of the 12 squiggly lines on the paper.
It is, and it's usually the one doctors ignore. But think of the ECG leads like cameras set up around a boxing ring to film a fight. Lead AVR is the camera that's sitting strictly on your right shoulder.
Okay, camera on the right shoulder. Got it.
Now, normally, the heart's electricity flows from the top right down to the bottom left, so it's flowing away from that shoulder camera.
Yeah.
The line should be negative.
Right.
But if you look at AVR and you see a big positive wave, meaning the electricity is coming towards the camera on your shoulder, that tells you the signal is starting at the bottom of the heart and moving up.
Which means it's coming from the ventricles. It's VT.
Bingo. A simple glance at that one forgotten lid can tell you do not give verapamil.
Yeah.
It's a lifesaver, but you have to look past the obvious.
Speaking of looking past the obvious, we have to talk about the text at the top of the paper. That little computer-generated diagnosis, normal sinus rhythm.
We're so conditioned to believe it. It's printed in black and white. It looks like hard data.
But Source 9 suggests we should basically treat that text like a hallucination.
It's the computer is always right fallacy. The study looked at atrial fibrillation, or AFib. The automated analysis was wrong nearly 30% of the time.
30%? That is a staggering failure rate for a medical device.
It is. And it cuts both ways. 11% were false positives. So the machine says, AFib detected. The doctor believes it, puts the patient on blood thinners, and now that patient has a major bleeding risk for a condition they don't even have.
And the other side, the false negatives.
That was 19%. The machine says normal, but the patient does have AFib, so the doctor sends them home, and now they're just a walking stroke risk because they aren't on the right medication.
What is confusing the machine so badly?
Well, it gets confused by pacing, if you have a pacemaker, or just simple tachycardia, a fast heart rate. But there's a new enemy in the mix, too. Source 22 points out our modern lifestyle is sabotaging the signal.
Is this the smartwatches and stuff?
It is. Electromagnetic interference, EMI. We are swimming in a sea of invisible signals. Your Apple Watch, your Fitbit, the tablet the nurse is holding.
And since the ECG is just looking for electricity,
it picks up that noise. It creates artifacts that look just like arrhythmias. So now you have a machine that's bad at math, trying to read a signal that's being jammed by your fitness tracker.
This feels like the perfect segue to the buzzword of the century, AI. Because the tech world's solution to bad algorithms is always better algorithms.
Right.
We've got ChatGPT, Gemini. Surely they can read an ECG better than an exhausted resident at 3 a.m.
You would hope so. But Source 7 actually tested this. They fed a bunch of ECGs to GPT-4o and Gemini.
Oh, wow.
GPT-4o had a 36% sensitivity for detecting a heart attack.
Wait, 36%? I mean, if I literally flipped a coin, I'd be right 50% of the time. The cutting-edge AI is worse than random chance.
In this specific task, yes. It was abysmal. And Gemini wasn't much better. It had incredibly high false positives. It all thought everything is a heart attack.
Why? These things can pass the bar exam. Why can't they read a heart strip?
Because they're language models, not visual processing models trained on cardiac physics. They hallucinate. The source said the AI would give a diagnosis and then provide a completely inaccurate diagnostic rationale.
So it was just making up medical logic to sound convincing.
Exactly. So relying on a general chatbot for medical advice is a terrible, terrible idea. But the sources did mention a bright side. There is AI that works.
Okay.
Yes, there is a massive difference between a general chatbot and a dedicated deep learning algorithm. There are tools like ECG Buddy or the Queen of Hearts model.
The Queen of Hearts. That sounds dramatic.
It's a hero, though.
Yeah.
This model was trained specifically on millions of ECGs to spot occlusions. In one study, it reduced false catheterization lab activations from 42% down to 8%.
That's huge. That saves time, money, stress.
And it's spotting things humans cannot see. It can detect subclinical dysfunction like a weakness in a heart muscle from a 30-second strip that looks completely normal to a human doctor. It is seeing patterns in the chaos.
So the specialized AI is superhuman, but the general AI is incompetent.
That's a good way to put it.
This conversation about what we can and can't see, it leads us to the final, and I think maybe the most important part of the stack, the equity gap. We've been talking about heart attacks as if they're one thing, but it turns out the very definition we use is biased.
This is the big shift from STEMI to OMMI.
Explain that. STEMI is what we hear on TV medical dramas. We've got a STEMI in Bay 3.
Right. STEMI stands for ST elevation myocardial infarction. It's a visual standard. Doctors look at the ST segment on the graph. If that line goes up above a certain threshold, it's a heart attack. Rush to surgery.
So it's basically a ruler on a page. If it measures 2 millimeters, we treat you. If it measures 1, we don't.
Essentially. But biology doesn't follow a ruler. Source 11 argues that this rigid criteria misses a significant minority of acute heart attacks because you can have an occlusion, a totally blocked artery, without that specific line going up.
So that's OMI, occlusion myocardial infarction. It focuses on the plumbing, not just the paper.
Correct. And who gets hurt the most by that old STEMI standard? Who tends to have atypical ECGs that don't show that classic tombstone elevation?
Women.
Women and the elderly. The sources are very clear on this. Women often present with symptoms or ECG patterns that just don't meet the strict STEMI criteria.
And the result isn't just a misdiagnosis, it's a delay, a critical delay.
Let's just pause on this statistic because it's horrifying.
Yeah.
The door to ECG, the time it takes from walking in the hospital to getting the test, it's 34 minutes for men. For women, it's 53 minutes.
That is a nearly 20-minute gap. In heart muscle time, 20 minutes is an eternity.
It is. And even when they get the ECG, if it doesn't scream STEMI, they wait longer for treatment. The source notes that these so-called non-STEMI patients often had higher rates of hypertension and coronary disease. They are sicker, but they're treated slower because they don't fit the visual prototype.
It seems like the recurring theme here is that we're prioritizing the proxy, the squiggly line over the reality of the patient.
That is the core message. We treat the graph. We treat the text at the top of the paper. We treat the stability heuristic. We need to get back to treating the actual pathology.
So where does this leave us? We've got crossed wires that mimic heart attacks, chest hair that mimics arrhythmias, deadly myths about stability, AI that hallucinates. It feels, well, precarious.
It is precarious. But knowledge is safety. The ECG is not a binary sick or healthy magic 8-ball. It's just one data point.
It's subject to sweat.
And in cross wires.
And cognitive bias.
And bad algorithms.
So for the listener, maybe the one stressing about the Super Bowl right now, what's the big takeaway?
Advocacy. If you or a loved one are in that bed and the machine says one thing but the patient looks like they're dying, or the machine is screaming but the patient feels fine, you need that human element. You need the overread. You need a doctor who looks at the patient, not just the monitor.
And as we wrap up, I want to leave us with a provocative thought about where this is all going. We saw that Queen of Hearts AI doing amazing things. It's detecting heart failure we can't see.
It is, but that creates a real paradox.
Right. We're moving from a world where we don't trust the machine because it's dumb to a world where we might have to trust the machine because it's smarter than us.
Exactly. If the AI says surgery now, but the human doctor looks at the chart and says, I don't see it, who wins? As these tools get better, will we eventually just surrender our judgment to the black box?
And if we do, will that save us from the misfits, or will it just create a new, silent kind of error that no human can even understand enough to catch?
That is the billion-dollar question.
Something to mull over while you watch the instant replays today. Trust the replay, but maybe question the monitor.
And maybe check those wires.
Thanks for listening to The Deep Dive. Enjoy the game, remember to breathe, and we'll catch you next time.